Hello and welcome everyone. I'm Dr. Israel Barkin, the Medical Director of the Prostate Cancer Research and Education Foundation. Every Tuesday at 6 p.m. Pacific Time, we have our Ask Dr. Barkin call-in show and we discuss articles. Now I'm going to present one of the abstracts that we brought up during one of our shows. Let's go now and look at this abstract. Comparing prostate-specific antigen triggers for intervention in men with stable prostate cancer on active surveillance. This study is from Toronto, Canada, from the University of Toronto. And it is by Lawrence Klotz. He's a very famous researcher dealing with active surveillance. So let's go now to the purpose. They determined the proportion of men with non-progressive prostate cancer on active surveillance who had a trigger for treatment using various measurements of prostate-specific antigen kinetics. So let me explain. Measuring prostate-specific antigen kinetics means the doubling time, the threshold, or the velocity. And these patients were followed with active surveillance, but not every time that there was a trigger because of PSA changes, they treated the patient. So let's look now at the methods of this study. It was a prospective study, phase 2, of patients with favorable clinical parameters. That means it was localized disease, stages T1b to T2b, and no metastatic disease and no lymph node involvement. And the sum of the Gleason was 7 or less, and PSA was less than 15. This is quite high by the standards of American doctors, but in Canada they took patients under observation with PSA under 15. And they put them on active surveillance. This was initiated in 1995. Of patients that were considered high risk for progression, they were offered radical prostatectomy. The remaining patients were closely monitored, and they formed the cohort for this study. They calculated the proportion and frequency of patients who had trigger for treatment based on various prostate-specific antigen triggers. Like I mentioned, the triggers are PSA doubling time, PSA velocity, and the threshold of the PSA. So they disregarded these triggers for treatment and used a broader rules about how to follow the patient. And here are the very interesting results. 450 patients were followed on surveillance. 305 remained on active surveillance without definitive intervention. This is about 3/4. None of these 300 patients have died of prostate cancer or have had symptomatic metastatic disease develop. The median follow-up was 6.8 years. So that's interesting that some of these patients had triggers of PSA to make you want to offer the patient a treatment, but they were not treated. They were continued to be followed up on the active surveillance. And here is what they found out over a period of median 6.8 years. The proportion of patients who would have had a trigger for treatment ranged from 14% to 42% for the threshold triggers, 37 to 50% for the prostate-specific antigen doubling time, and 42 to 84% for the velocity triggers. That means that those patients had some triggers along the follow-up, but they were not treated, and it was not used as a trigger for treatment. And the reason here is the fact that there is great variability in the PSA, jumping all over the place, and sometimes you just wait and you find out that criteria, trigger for treatment, actually changed just by waiting a bit longer. So their conclusion is almost all of the prostate-specific antigen triggers examined in this study would have led to a higher rates of trigger for treatment. More work is needed to identify a trigger that better strikes the balance between recommending treatment for patients at high risk for progression and minimizing treatment for those at low risk for progression. If you want to hear more about this, please get on our website www.pcref.org and look at past shows. And during the show on October 26, 2010, I discussed these articles in more details. Thank you for listening. Take care, and just to remind you, the number to call the show live every Tuesday is 1-877-727-3301. Thank you for your attention. Goodbye.